A production fee for your Hometown Health Connection was made by Buffalo Healthy Living Magazine and its sponsors.
As the state continues to navigate COVID-19 inoculations, many Western New Yorkers are looking for answers on vaccine development, safety, and effectiveness. Demand for the vaccine is high, supplies exceeding demand, but improving. But some Americans are choosing not to get vaccinated due to fear and safety concerns. Viewers sent in their questions, and Buffalo Healthy Living magazine compiled those questions for today's town hall. To provide us with answers surrounding the pandemic is Dr. Kenneth Snyder, Vice President of Physician Quality at Kaleida Health, practicing at UB Neurosurgery and co-director of an international organization teaching stroke treatment throughout the world. He is a fellow of the American College of Surgeons and a fellow of the American Association of Neurologic Surgeons and an assistant professor of neurosurgery and radiology at UB's Jacobs School of Medicine and Biomedical Sciences. Dr. Snyder has over 150 peer-reviewed publications and is currently in the middle of a master's degree in applied science and healthcare quality and patient safety at Johns Hopkins. And Dr. Raul Vazquez, President and CEO of G Health Enterprises, a primary care physician practicing medicine in Buffalo for 30 years, a fellow of the American Academy of Family Physicians. Dr. Vazquez saw a need and opened Urban Family Practice on Buffalo's West Side in 1996. Since then, he created Greater Buffalo United Accountable Healthcare Network to become one of Buffalo's largest minority employers, serving thousands of patients on Buffalo's West Side. He is also on the governor's COVID task force. I'm Samantha Latshaw. Welcome to your Hometown Health Connection. As more Americans across the country receive the COVID-19 vaccine, there are more questions. There is growing concern on how the current vaccines on the market protect against the new strains popping up across the world. Right now, there are 3 circulating in the United Kingdom, in Brazil, and South Africa. Experts say some are more contagious than the original virus. We know you're curious about the safety of the vaccine and its effectiveness. Here to answer all your questions surrounding the pandemic is Dr. Kenneth Snyder and Dr. Raul Vazquez. Doctors, welcome. Thanks for joining us. We'll start with Dr. Snyder. Most of the public health experts say that anywhere between 70 to 90% of the population would need to be vaccinated in order to achieve herd immunity. But efforts to distribute the vaccine have been slow due to limited availability, logistic issues, and fear.
Complex question. First, I'd like to thank you all for taking the time to help us communicate with the public. And Dr. Vazquez, I want to congratulate you on opening your vaccination clinic today. Thank you for your service. Conversations on herd immunity, again, are complex. It's a conversation that asks the question of how many people need to have antibody protection to stop a virus from spreading through a community. And the viral spread conversation typically talks about an R naught value, which means that the community hasn't been exposed to anything. We are in a phase where about 26 million Americans have already seen the virus and likely generated then their own antibodies. In addition to that, we've vaccinated 33 million Americans so far. So almost 15 to 20% of our population has some form of immunity. The numbers of cases that we report, however, are often symptomatic cases. And we know that the vast majority of this disease is spread asymptomatically. So we don't know the exact number of where we are at right now. The reason you've got this range of numbers of do we need to be between 50 or 80 is because it's hard for us to predict how fast this can spread. And the fact that certain variants may spread faster than others makes it complex. The way I like to try and simplify this is imagine the concept of you've got a fire and dry grass everywhere. How much of that grass needs to be watered down so that the fire can't spread? And that's the question that we're trying to answer. And it's a combination of people developing a natural immunity themselves and an ability for us miraculously to leverage technology to get our immune systems to develop antibodies as if we had the virus without actually having it, but allow us that protection to stop its spread.
Many people are asking, why should I trust these new vaccines when they were made so quickly?
You know, I think we have to understand that the technology for these viruses has been around for 20 years. The technology from J&J, which uses a DNA adenovirus, has actually been FDA approved and in use for Ebola since July of last year. But the technology has been around for 20 years. The mRNA technology has really been developed since the first SARS and MERS, so almost 20 plus years. What's really happened is that what would have been a serial process of learn and make something work in a bench top and then in an animal model and then do trials, and then once it works in trials, start to worry about production and then distribute. The collaboration of science around the world and governmental agencies is what's sped up this entire process. The distribution network, the production capabilities, and the science, we're all working collaboratively at the same time. And if there's anything that I can say about what we're seeing in the data for every one of these different vaccines, that's Moderna, Pfizer, the AstraZeneca, which we're waiting on peer-reviewed data, the J&J, and Novavax, even though they all have different technologies, they are all 100% effective for hospitalization and death, even amongst the variants. That is a huge and important piece of information to share with the public. Where we are seeing the nuances are what we call effectivity for symptomatology, and whether or not there might be 66 versus 85 versus 90% effective. Anything over 50% is probably more than we need for us to at least feel safer than we would without ever having any vaccine on board to protect us alone.
Doctors, there's still data coming in on this. You know, there's a lot of concern and fear among women who are perhaps looking to become pregnant soon or are pregnant, and the fear of what they could do to them and their unborn child. Please talk to me about that, especially with the women who want to have more of a natural approach and not take in any type of medications during their pregnancies.
We definitely know that pregnant women, if they get COVID, they get severe COVID compared to women that aren't pregnant. So that's one thing. Number two is that, you know, especially if you're pregnant and you are working in the healthcare industry, your risk is so high that you should get the vaccine. And that's my recommendation. You know, you should talk to your doctor. And that's the advice I would give to not only my patient, my daughters, if that was the situation. And that's why, you know, it's so important. I think the other side of the equation here is that, you know, when we were talking about the trials on this vaccine, some women were pregnant that didn't know they were pregnant. And then they found out later through that whole process, and they're being monitored. But for many, many years, I mean, especially this COVID is like a virus type of vaccination, a little different because this has nothing in it. This is just tricking the body. You know, the old flu, we take pieces of the flu, and that's what we use for an injection, and they use an egg, so if you have allergies to eggs, it was more, and we've done that forever. So if my recommendations are to people, if you're breastfeeding, because we had people that were vaccinated on our line that worked at the office that asked the same questions. Pregnant, breastfeeding, is it safe? And I say, well, if you're working here and you're exposing yourself, the incidence of severe disease and death and all that stuff this is your risk versus taking the shot right now. So you've got to make that decision. And I'm talking to some of these individuals that were my sister-in-law, other people that are close to me. So I mean, because the data shows that. Now, is it totally, you know, perfect? We don't know. But at least when you follow the data and what we've seen, I would advocate, and I think the American College of OBGYN advocates, talk to your doctor, but they feel strongly that people should be vaccinated, especially because of the risk it carries not to be vaccinated.
What would you say to calm the fears of the mother when the child 5 years from now? Of course, this information is not here yet, but I know there's mothers out there that have that fear. What would you say to them?
Well, we had the Zika situation, in other parts of the country, and vaccines that were developed in models really had the same type of tech to protect that from occurring if you get exposed. So, we don't know. I mean, I wish I had a better answer, but I always put into effect the cost benefit or something. And right now, the cost of not doing this is so high and the benefit so good that we really have to, make a conscious decision. Talk to your doctor, look at more data, but at the end of the day, my recommendation is if it's my patient, someone in my family, I'm usually recommending for the vaccine because I know what the COVID can do to people. And most of these severe cases with pregnancy are on ventilators. It's really bad, severe outcomes where the child may be in danger because you went through that next stage. So the risk to the child is much higher if you have severe COVID than if you have the vaccine.
I think the only other element to add is that if you're thinking about getting pregnant and had the opportunity to wait, it would be recommended get the vaccine, get your second dose, and then move forward with attempting to get pregnant. That's only if the opportunity arose. Almost everyone that I've had the conversation with that's had the conversation with their OB-GYN gets the vaccine. So it's not that you're having a conversation with them and the vast majority of people are being told, no, don't do it. It's more of making sure it's on their radar, that it's a combined conversation, that you're educated similarly to the way we're talking today, and all of the questions are answered that could be answered as best they are. And I am always hesitant about ever saying anything with absolute. And that's what makes our lives so difficult, and that's the art form of practicing medicine. So I agree with everything Dr. Vazquez said.
Okay, what about, should you get the vaccine if you already had COVID, and how long should you wait between the vaccine after recovering?
So I think usually 14 days after, if you had COVID, that's my recommendation. Because one of the things that happens is when we give the vaccine to someone that had COVID, it triggers. You have memory cells or these cells in your body that respond to the injection itself. So those individuals, what we're finding out from them is that they're experiencing symptoms like fevers, joint pain, usually last, and the fevers could be 102, 103. They last for 24 to 48 hours, and usually Tylenol and Motrin resolve that. But most people that don't have any of that exposure usually just have pain at the site for the first injection. And I've actually both of them. So we have about 220 people, and 200 have been vaccinated, and we all got our second shot. So we've been kind of following through and talking through the process. Because I think the more you know about the process, the more comfortable you are, especially when you go in and you see people's anxiety before they even get the shot. Today, we gave 360 shots, and it's always the same type of cycle to really get people comfortable.
Absolutely. What about other vaccines such as the flu shot or shingles? What's the wait period between that and the COVID vaccine?
14 days. You want to give that space and time. So if you were vaccinated with the flu before that, you really want to wait 14 days.
Dr. Snyder, what are the risks of serious side effects from taking the vaccine versus the risk of getting seriously ill with COVID?
Sure, it's a great question. So the first thing is understanding somewhat the natural history of the COVID. And I think what's important in understanding that is recognizing that with the way that it's been a year, just beyond a year of peer-reviewed publications in it, and how much we've learned in a year is incredible. But the current data suggests, unlike with the first SARS 20 years ago, which went away on its own, that this will likely stay around. And because of its ability to spread asymptomatically, because its ability to live within animals, so there's an expectation that this will stay here. Why is that important? Some people feel that if they don't get the vaccine or stay away, and that they'll never get this virus. And I think what people need to understand is that they need to be making a decision between whether they want their body to fight COVID without any protection on board, or whether they want it with the vaccine. And I think that's an important distinction. Without a vaccine, or what COVID illness shows us, And New York State is a good set of data to use. And we often talk about the fatality of it, but the fatality may not be all there is to this illness. But from a fatality component, looking at the distribution, 4.5% of all the deaths occurred in less than 50 years of age. So 95.5% of the deaths in New York are people above 50. And with each decade above that, it gets higher and higher. So first of all, we know there's an age distribution of this illness and severity. We also know that about 80% of people have mild or asymptomatic infection, and 20% or 15% can have a severity of illness that requires either hospitalization, and a much smaller percentage of that in the ICU. So I think the take home from this is this illness, although the vast majority can be mild or asymptomatic, can have severe consequences. And what we live every day in the hospital allows us to refresh our minds of how severe this illness is. And what makes this illness also different than an influenza is the amount of longer-term side effects that people have. And so seeing these people long-term and the consequence on lungs or the heart or other organ systems is important. So with that in mind, we think about what are the risks of the vaccinations. First of all, there were no serious adverse reactions and difference between the placebo and the vaccinations. And in the studies, most of the studies had about 30 to 40,000 people in them. Realize we now have data on 33 million Americans, and we'll continue to get more. The most common reactions are reactions that go away in a day or two that Dr. Vazquez had pointed out. And the reason that people are having these reactions is because they have healthy immune systems. Now, it doesn't mean that if you don't have that reaction, you don't have a healthy immune system, but it means what you're feeling is your body learning how to fight this virus and fighting the site where the injection went in. So pain at the injection site, redness, swelling. The reason you generate a fever is because that's your immune system mounting, headache and chills, joint pain, diarrhea. These are symptoms that can occur between 10% and even 50% of people that get it, but they're short-term, they're self-limiting, and they're often because it's your body learning how to fight this vaccine. It's called reactogenicity. The one reaction that's unique within Moderna and Pfizer that may or may not be occurring in J&J and others is 1 out of 100,000 people may have what's called an anaphylactic reaction. It's why we watch people for 15 minutes to 30 minutes. And it's why we say anybody that's had a serious allergic reaction to a previous vaccine needs to let us know, because we pre-medicate that person before they get their vaccine. It doesn't mean they don't get it. It just means we watch them that closely. But think about 1 out of 100,000 people is 0.001%. That's the level of concern that we have around this. And that's an incredible safety measure.
Absolutely, when compared to actually what could happen if you do get coronavirus. Now, doctor, should you take any over-the-counter medications to address those type of side effects?
CDC recommends not unless you develop symptoms. I can tell you from my personal experience and sharing with others that, by that second day of the second shot, as you're potentially developing symptoms, and the frequency of which are really 1/3, people, that Motrin, if you can take Motrin, or Tylenol, if you can't take Motrin, can really make a difference in helping that next day or two get you through that. But as you're going through that, I don't want you to worry about the fear of, I'm going to have arm pain or some shakes and chills for a day. I want you to think about, I'm building an army of response to this virus so that if I ever get it, I'm ready to fight it immediately. And that's really what's happening.
Is there any evidence of worse side effects from the vaccine in patients who actually have had COVID?
Yeah, that's what I talked about. Yeah, because we develop 2 types of cells when you're exposed to COVID. One's are beta cells, memory cells, and T cells, and the memory cells. So when we kind of trick the body, it's making these spike proteins. They look like spike proteins. All these cells that were already there cause the reaction to occur, and that's the symptoms that people often get. Like my daughter had COVID back in March. When she went through the vaccination, she experienced the arthralgias and the fevers of 102, 103 for about 24 to 48 hours, but just Tylenol and Motrin during that time alleviated. But it's telling you that she's already kind of active. And there's some literature looking at that people that had COVID may only need one vaccination, not two. So we're looking at, I mean, it's an evolving process right now. What you don't want to do is pre-medicate before you go in for the shots. I think that's real important because using Tylenol Motrin can actually interfere with the response to the vaccine itself. So afterwards, okay, not before.
I see. So not using any pre-medication over the counter beforehand, but perhaps after if you do have some of those mild symptoms.
Absolutely.
Very good. Dr. Snyder, will the current vaccines be effective against the new variants?
So again, it's an emerging. What we have to remember about science, number one, is that we don't know everything. We've got to learn never to say anything almost in absolutes, and that we will continue to learn about this each day and in years to come, especially with the amount of science coming out right now on all of the different vaccination trials coming in. What we know, I'd like to reiterate what I said before, is that even in the trials that were occurring in the UK and in South Africa, where the variants were very prevalent, some of which were even 90% of the patients, there was 100% efficacy for hospitalization and death. Where we're seeing the difference in the variants is what we call mild or moderate symptomatology. And so for people that may have seen the original, let's call it, or a more standard version of this virus, where it might have been 90 or 95% efficacious, that number may drop down into the 60s. That's still very, very good levels of protection. And what do we mean when we say variants? I think this is important. This virus, which is a coronavirus, is more stable than many of the other RNA viruses, than something like influenza, which changes very rapidly. But it still is able to change. And so when we get sick with this, we can make millions of copies of this virus and spread that through respiratory drops when we're infectious. Of the millions of virus, there might be 10,000 of which that have mutated and are a different variant. And so we're constantly spreading, if we're infectious, not just one, but a wide variety of different versions of this virus. And that's how variants can become prominent and can spread. So this isn't new. It's not a new phenomenon. Our body has learned to adapt and beat this because every time we get sick, we get stronger and learn how to fight what we're seeing. Think of the common cold. We can get it multiple times in a year. Each time we get it, it's not really as severe, but what's happening is our body's getting stronger and learning how to fight. The same thing will happen with this virus and its different variants. When we hear the term strain, that means that one of the variants has learned to make us more sick or change the pattern of illness that we have. And we haven't seen any of these different variants become called strains. They may, the same theories will approach them. And the really neat thing about some of these vaccines is that we can quickly adapt them to the new versions of the virus. And so again, the technology and our ability to leverage how our normal natural immune system has learned to fight these viruses is truly incredible.
Doctor, do you think we're going to need a booster for these variants, and how soon would that be available?
So
really hard to predict.
Yeah.
Excited for the science to lead us to that. But the suggestions are that this may become something like the flu where we need boosters each year. And the technology platforms for each of these vaccines are set up to be able to make those levels of change if needed.
Dr. Vazquez, you want to comment to that?
Yeah, and I kind of agree. I'm hoping that based on the data, because we're not looking at the T cell memory part, that it's going to resemble the measles. I believe that it's going to be more of not just eliminating, and this is stuff that as you start to evolve, with measles, when you get a measles shot, not only prevents you from giving it to other people, not just getting the measles, and I believe that the literature will point more to that direction. So it's just important to get the vaccine itself. I mean, there's so many variables that's so good for it that having gone through it, I think it's something that we're all going to need to do, because I believe as the data comes out, AstraZeneca study is showing that infection rates because their study was done differently. They did nasal swabs on everybody, whether you were sick or not. The other trials didn't do that, and what they found is viral loads were less after the vaccine. So that tells you that these patients may not be able to pass it forward to anybody else. So not only are you preventing yourself into getting into severe cases of COVID, second is you may be protecting your family and the people around you. And hopefully we can get out of this situation that we're in with that. And I believe it's a class effect. It won't just be one thing, but at least there's light at the end of the tunnel.
Very, very promising data so far. Dr. Vazquez, is one vaccine safer than the other, and can you request which one you get?
Well, I think the best vaccine is the one available to you. I think, right now, today, we were able to get Pfizer, and we gave 360. People were it's just hard until the production line comes in. I think Pfizer a little trickier because of the storage system. I think the Moderna becomes a little bit easier, but the J&J and some of the AstraZeneca, based on, remember, all these vaccines have really cut down on severe COVID response or disease. So the AstraZeneca and J&J will be a lot more user-friendly. Some of the trials we're looking around, UK decided to do it a little bit different with the AstraZeneca, where they're just giving half a shot and then a follow-up shot, and they spaced it out for about 6 months because they're getting that effect. So we're still learning, and there's still a lot of evolution, but the pipeline's getting better. But the best vaccine for you is the one that's available at this time.
Dr. Snyder, to help ramp up vaccination rates, could just one dose of either the Pfizer or the Moderna be given, and how much immunity does just one dose provide?
Really tough question and good question, and it follows up on Dr. Vazquez's point. The AstraZeneca study is a very interesting study that we're very excited to see come out in peer-reviewed literature. The first point that Dr. Vazquez brought up is that it's the only one that really looks strongly at asymptomatic spread, and there was a 60% reduction in that. That's critical. A subset of Moderna had similar results, but it wasn't a key part of the study. The other part of the AstraZeneca study was that, and it's going to make it complex in its analysis, was that its entire protocol wasn't followed explicitly. There was a period where people got a half dose, and then their secondary dose was a different amount rather than a full dose. And then they did it over various timeframes between 4 weeks apart and 12 weeks apart. What's most interesting about this study is that people had the most robust response when they waited the longest period of time between them. And so the UK's made an argument that people were 84% effective against symptomatic disease, even through that one-shot period all the way up to the 12 weeks. So why don't we, as a nation, only give the single shot so that we can get to as many people as possible? And they did the analytics to support that with that data set behind it. So again, it's going to be interesting to see how that evolves. What's also interesting is in the FDA submission for Pfizer from 12/10/2020, at day 12 after the first injection, you see a significant number of people protected against symptomatic disease, almost 80%. And so to Dr. Vazquez's point, we want to follow the trials the way the trials were done because that's the data we believe. But more and more, we're going to learn about if we can modify or make tweaks to them to be able to distribute more vaccine and still offer the protection that we know people need.
Dr. Kenneth Snyder and Dr. Raul Vazquez, thank you so much for joining us. We look forward to having you return next week to continue the conversation.
A production fee for the preceding presentation of Your Hometown Health Connection was made by Buffalo Healthy Living Magazine and its sponsors.